Well, good afternoon, everybody. This is Jake Galdo, PQA's Director of Education and Program Development, and we are incredibly excited for our first Quality Forum of 2020. Today, we are going to be having the presentation called Connecting Capital to Healthcare Payers and Providers in Opportunity Zones, and we are joined by John Gorman and Pam Taylor of Nightingale Partners. Just a reminder, a few of some of the logistics for our quality forums. Send us your questions. You have a question field off to the right in your control panel. That is where we'll be able to see your questions, and I'll be able to kind of Q&A that towards the end of today's presentation for John and Pam. This is also being recorded, and it will be part of PQA's member resources. So if you want to catch, or you missed something and you want to catch it later, go ahead and find that recording and let us know. And then at the end of the presentation, you'll also have a quick survey. So please let us know any feedback. We always like to remind people of the next quality forum that we have. And so our next one's going to be Thursday, February 20th. It's going to be about interoperability and quality with Pioneer RX's Josh Howland. Please note that even though I'm saying the next quality forum is February 20th, we actually have a variety of other webinars occurring within PQA over the next couple weeks, including one today at the top of the hour. So we're going to go ahead and have a PQA measure endorsement all-call webinar coming up at the end of this, so be prepared to stay with PQA for your entire afternoon. Additionally, we'll have a technical educational webinar in about 2 weeks, and more information on that will be coming at the end of today's slides. So I'm really excited for today's presentation. For those that don't know, we had a quick preview of what John and his team are doing back at our Caring for the Whole Patient Forum preceding the PQA Leadership Summit in November of 2019. And so after that amazing presentation, we asked them to come and share what they're working on to our larger audience as part of our quality forum, and we're very excited for them to be our first quality forum of 2020. So as a brief bio for our two speakers, John Gorman is the founder, chairman, and CEO of Nightingale Partners. John started and led the Gorman Health Group, a leading consulting and technology firm in government-sponsored health programs for 22 years. Prior to founding the Gorman Health Group, John served as a top official appointed to the Healthcare Financing Administration, which is now CMS, by President Clinton, and served as the Chief of Staff to U.S. Representative John Coyers, Jr. He serves on the editorial boards of the Atlantic Information Systems and Bloomberg Government and is frequently quoted in national media outlets. Additionally, John's going to be joined by Pam Taylor. She is the Chief Innovation Officer of Nightingale Partners. In this role, Pam architects all Nightingale investments and offerings. Prior to joining Nightingale Partners, Pam served as the Vice President for Community Impact at WellCare and as an Executive Director of WellCare Community Foundation. She has served as the Senior Executive roles in Social Determinants of Health Management at United Healthcare and LA Care Health Plan. So again, John and Pam, thank you so much for joining us today. And I believe I'm going to go put myself on mute. And John, I'm handing it off to you.
Great. Thank you, Jake. It's a great pleasure to be back with you guys in PQA. And hello, Pam. And to all of us who made time to join us today, we're thrilled to have you. It's our great pleasure to speak with you guys today about the state of supplemental benefits in Medicare Advantage and in Medicaid, the arms race in social determinants of health, and some of the new sources of capital that have become available to plans and providers in the industry to help pay for these new benefits and services as a way of helping to take some of the risk out of offering these benefits going forward. So let me just get control of our slides here. And here we go. So let me cut to the chase. I think for those of us on the line, we are all aware that Medicare Advantage and Medicaid managed care really remain the sole sources of revenue growth for plans, providers, pharmacies, and for PBMs. I think we're all aware that the commercial insurance market is shrinking as fewer and fewer employers offer health insurance benefits to their employees and even fewer to their retirees. And as the country gets older and poorer, Medicare Advantage and Medicaid managed care have really surged and are continuing to do so for the foreseeable future. These two programs are actually the biggest laboratories on the planet for both value-based payment and for social determinants of health benefits enabled by some great new policies that surprisingly came out of this administration, and abundant and growing body of evidence that shows that social interventions in people's health care, especially for the low income and the chronically ill, are investable opportunities that typically pay a 3 to 8x ROI just by investing in basic human needs and social services programs. And as David Cordani of Cigna wisely pointed out this week, I think we've all come to learn in this last couple of years that social determinants interventions are really the only hope to bend the curve on healthcare expenditures. And as Cordani stated, you know, Cigna's entire margin is tied to its ability to manage social determinants of health. And I think the faster all of us come to that realization, the better. We have flirted with everything from disease management to population health. And I think we've all come to the realization that you just can't manage diseases in a vacuum, that you really have to look at the whole patient and the circumstances in which they live in order to really try to manage their care most appropriately. We at Nightingale in this last year really came to the realization that the Opportunity Zone program is really the best vehicle that we've found for financing and sustainably financing social determinants interventions. I looked a lot for about 3 years at social impact bonds, which is about a $50 billion market. But when Opportunity Zones came out in Trump's big tax giveaway bill, you know, I just kind of scoffed at it and I didn't really pay much attention to it. But the more I looked at it, the more perfect it was for investments of this sort. Opportunity Zones are about 9,000 designated zip code tracts across the country that are both economically disadvantaged and medically underserved. And and the program says that if you invest capital in one of these zip code tracts, that not only is that capital and leave it in that market for at least 10 years, that money will be exempt from capital gains, as will all the profits and proceeds made on that investment will be completely tax-free. So as you can imagine, that unleashed a gusher of over $6.2 trillion in available capital. And we found that that this program and the torrent of cash that it has made available for investments in these underserved communities is really the perfect vehicle that we could have asked for long-term sustainable financing of these types of interventions and benefits. So we view this as both a Darwinian moment, and as you know, Darwin obviously famously pointed out, you don't have to be the biggest or even the strongest or the smartest. You just have to be the most adaptable to survive in a moment like this. And a great example of that has been Anthem. I don't think anybody would accuse Anthem of having been an innovator in its government programs until 2019, when they came out with their supplemental benefit package in Medicare Advantage following the new CMS policy. And it was really groundbreaking in terms of the kinds of things that they were covering and experimenting with. And that's a perfect example of Darwin's treatise. And as a result of that innovative benefit design, Anthem leaped forward in this last AEP and is really starting to clock some numbers that you would expect with a big national as they are. But it's also Edisonian, because anytime that we're talking about intervening in the lives and the healthcare of really vulnerable, poor patients, as Edison said, you know, vision without execution is hallucination. And what really requires to make these investments pay off is a really intimate understanding of the population that we're trying to intervene with, the specific cohorts of folks that we're really trying to reach, and then execution at the ground level in coordinating with community-based organizations and all sorts of other assets to bring these benefits into folks' lives in these underserved communities. All right, Jake, I am trying to advance to the next slide. Oh, there we go. Okay.
I can
here it is
covered.
in a nutshell. Yeah, you got it. Yeah, we got it. here we are in a nutshell. You see the decline of the commercial insurance market, and you see the surge in Medicare Advantage and in managed Medicaid. And as the country continues to get older and poorer, you're going to see these numbers get more exacerbated in the years to come. Jake, if you go ahead and advance the slide, I'm having trouble again. There we go. And you see the stunning growth in Medicare Advantage in this last 15 years, where, you know, back in my day when I was running this program for the Clinton administration in the early 90s, if you had told me that we would be at 36% penetration at the dawn of 2020, I would have told you were smoking something excluded from Medicare Part D. But here we are. We've got 36, closing in on 37% penetration in Medicare Advantage, and on track. Go ahead, Jake. I can't get these slides to go. And on track, as you see, to what will be 50% penetration, most likely by the end of 2024. And in some of the more mature markets around the country, like Florida, like Minnesota, like Oregon and California, and in markets within those states, like Miami-Dade County is now over 65% penetration of Medicare Advantage. You see similar numbers in the Twin Cities in Minneapolis and in Southern Cal. This program has really gone mainstream and is on pace to represent half the program within just the next couple of years. Go ahead, Jake. And as I said, and as my teenage daughters like to say, we're looking at explosive growth in Medicare Advantage forever. And we'll be at about 50% penetration by 2025 at the pace that we're on. Go ahead, Jake. Now, the reason we really want to pay a lot of attention to social determinants and what we got to do to bend the cost is that up until relatively recently, Medicare Advantage has really been a revenue gain for the plan. The more STARS reporting you did and the better you performed on the STARS measures, and the higher you got your risk adjustment score, your RAP score, that was pretty much the whole shooting match. And as long as you were doing well on revenue, generally speaking, your MLR was going to be, you know, in the 80s. Now, what we're heading into is expected, according to the Medicare Trustees report, to be a relative drought in the increase in Medicare Advantage payments, and that we're going to see some flatlining here in this next several years, where the rates are going to go up at a lower and flatter trajectory than we've been used to, certainly since the Medicare Modernization Act back during the Bush administration. That means we got to turn our attention to our medical loss ratios, and that means we got to look to what's going to help bend the curve on the clinical care side in order to ensure that our medical inflation rate keeps pace with this lower, flatter rate of revenue growth in the program. Go ahead, Jake. And as you see, you've just got a very similar situation over in Medicaid as well. Medicaid now covers over 75 million Americans. It pays for most of the births in this country. It pays for almost all of the long-term care bill in this country. Go ahead, Jake. And so, you know, the thing that's always characterized the program is that moms and kids will make up the majority of the population, but only a minority of expenditures. That you've got the elderly and disabled, the dual eligibles, and the IDDs, as we often refer to them. They represent less than 25% of enrollment in the program, but over 2/3 of its spending. So Medicaid has basically become a long-term care financing program. And it has become, to be clear, go ahead, Jake, long-term care has become the #1 or #2 item in every single state budget. So it's crowding out roads and bridges and education, and what drives all of those expenditures, of course, are the proportion of dual eligibles in that state. And this is the biggest opportunity going for the insurance industry, and also represents the most vulnerable and expensive and complex patient population that we could possibly ask for. Of what we think are probably around 14 million duals, only about 1 million of them are already enrolled in health plans. So this is an enormous opportunity in the future. And in the waning years of the Trump administration, I expect we're going to see a flurry of waivers from a number of states to try to move even more and more of the duals and the disabled into managed care plans. Go ahead, Jake. And that's where you're seeing the explosion in what we call Medicaid long-term services and supports. MLTSS is really the effort that's underway in about 37 states right now to really do a lot more nursing home diversion and a lot more independence at home and hospital at home types of programs that are designed to keep people out of human warehouses like SNFs and CORFs and try to keep them in their homes and communities for much longer. We're going to see an explosion of MLTSS waivers in this next couple of years, and all of these things revolve around better management of social determinants. Go ahead, Jake. So, Pam, I'm sure you have a lot to say about this one, but I think the research has been very well established that social determinants are responsible for more than 60% of healthcare costs in this country. And when you're talking the elderly and disabled, that number is closer to 80%. And it's all about where people live, how they live, who they live with, what they breathe, what they eat, what they drink. And all of these things contribute hugely to healthcare costs. Go ahead, Jake. Because we only spend less than 1% of our gross domestic product on our social safety net, ironically, it now falls to health insurers to basically, who are responsible for 100% of the healthcare costs of their members, of course. It falls to health insurance companies to also now become social service agencies to better manage their medical loss ratios. And that's why social determinants have become a top priority for most of the nation's health systems, and why the vast majority of those execs say that mastering this stuff is a top priority. Go ahead, Jake. And that was what brought about the new MA Supplemental Benefits policy in 2018 that really opened the floodgates to all of these new types of interventions. So the policy said you can now include in your benefit design and in your bid in Medicare Advantage benefits and services that reduce avoidable emergency and healthcare utilization. The challenge with this great new policy is that they offered no new money to do it with. And as a result, the plans have been scrambling in the last 2 years to pay for this kind of stuff out of their own treasuries. But what that does is it impacts their competitive position. Any new benefit that you put into a bid is going to impact premium. And the entire basis of competition in Medicare Advantage is a zero premium product. So the MA plans have actually been relatively timid about jumping into these types of benefits for that reason, as well as for the fact that actuaries who really run insurance companies really are struggling to get their heads around non-clinical benefits. And, many of them are still of the opinion that these are largely unproven, untested types of benefits. And, we have to proceed cautiously. We would like to argue otherwise. Go ahead, Jake. And so we estimate that there's at least a $200 billion market just within the senior market alone in managing social determinants of health to get to better quality and lower cost for lower income and vulnerable beneficiaries. And that's why we're seeing this arms race in the space and such huge investment by health plans and health systems alike. Go ahead, Jake. So what we've got here, and I'm just going to give you the high points here and let you guys read through this at your leisure as some stunning bathroom reading, is just a little sample of the overwhelming and growing body of evidence that these types of anti-poverty interventions really pay off in terms of reducing healthcare expenditures. You see some of the results here for housing and home safety. Go ahead, Jake. You see some of the results that we've seen across the country, from New York to LA to Pittsburgh to Indiana. The savings are almost overwhelming. Look at what UPMC did there in Pittsburgh that with a very intensive program, net of the cost of pharmacy counseling, they saved a net of almost $6,400 per member per year by a supportive and transitional housing for members with polypharmacy who were housing insecure. Go ahead, Jake. And so the research consensus is that housing is really one of the most beneficial and high return interventions in social services that you can do, but they often have very high capital requirements and time to deploy as a mitigating factor. So we've been working on some initiatives and a couple of projects that we're working on to try to find some creative and alternative sources of housing stock for vulnerable populations. We're finding things like corporate housing chains are often have a lot of vacancies. And so, for instance, in one project we're working in Los Angeles, we've gotten Extended Stay America and Candlewood Suites and others to be willing to put up hundreds of their suites to be available for recuperative beds and for temporary and supportive housing for up to a year for members of LA Care there. And so that's a nice way of being creative and entrepreneurial and figuring out some housing solutions here. Go ahead, Jake. Social welfare benefit enrollment is really one of the best things that you can do for your members. Just signing them up for existing social welfare programs that they are already eligible for, like low-income heating assistance, housing support subsidies, even food stamps, have a huge impact on health, as you can imagine. Go ahead, Jake. And not only unlocks some unclaimed risk adjustment codes as you work through eligibility for those programs, but inevitably, anytime you help members sign up for other social welfare programs, it's going to have a very favorable impact on your star ratings because they love you for that kind of help. Community health workers are the center of any meaningful social determinant intervention. These are basically social workers without the degree who live in these vulnerable communities. They know their way around these neighborhoods, and you train them in good healthcare navigation and in helping a panel of their patients get through the system and seek care at the right location and at the right time. And you have enormous savings that result from the use of community health workers in any of these interventions. Go ahead, Jake. You see very similar results in transportation. I think we are all aware of how transportation challenged many of our vulnerable beneficiaries are. And even with companies like Uber and Lyft jumping into this, we don't want to get comfortable with any kind of notion that a transportation benefit is easy to administer or a sure thing by any means. These types of benefits are really kind of fraught with peril for the plan, because all the mischief in a transportation benefit occurs between the member's bed and the curb. And very often where you get problems is when you don't have drivers that are experienced in dealing with mobility challenged members, and you don't manage the actual logistics of getting that member in and out of the home and into the vehicle and into the appointment. It's actually a lot harder than you would think with many of these mobility impaired bennies, and it can be a real source of CTMs and complaints in these programs if it's not appropriately administered. Go ahead, Jake. But when done right, it's an enormous saver and a huge contributor to higher star ratings. Almost no intervention, though, even comes close to the impact of food security and of having a meal delivery benefit, especially for those who are homebound. And then for those who are in need of medically appropriate meals, like those with diabetes and with chronic kidney disease. And everything that we have seen shows just some staggering savings from this. My favorite study of all time is the one from Geisinger a couple of years ago that showed that, they found they were spending almost $300,000 per patient per year on their uncontrolled diabetics. And when they got these folks a medically appropriate meal delivery program, within 14 months, they had dropped their average cost net of the meals by almost $200,000 per patient per year. So that was an ROI of 35x. When most social determinants interventions run 3 to 8x, you can see why that one was just such an incredible home run and illustrative for the rest of us of what we could maybe expect with a similar program. Go ahead, Jake. Loneliness and social isolation. I think we've all come to realize that for vulnerable populations, being lonely and isolated is the equivalent of smoking 15 cigarettes a day. And it's known to cause up to $7 billion in expenses just in Medicare alone. Almost half of seniors report feeling lonely. I mean, this is an epidemic in this country. It contributes to depression, and depression is a 4x multiplier of the cost of any other chronic condition in effect for that beneficiary. Go ahead, Jake. So to give you a little summary of the research, this is the size of the market. These are the potential savings that you can expect. And as just a great summation of the research and as a means of allaying concerns among the actuaries who really run the companies that most of us do business with and work for, this is one that I hope you'll keep referring back to. Go ahead, Jake. So as you're approaching this, some guiding principles are a really good idea. And these from the Long-Term Care Quality Alliance are a great place to start. But generally, you want these benefits to be clear, easy to understand, that they're equitable and targeted to those with greatest need. That is the real challenge in our experience at Nightingale thus far. Plans know, I think intuitively, that there's needs among their more vulnerable members. But when you start to turn to the data to actually identify actual patient cohorts in need of intervention, that's where we find so much of the data is lacking because so few plans and providers screen for social determinants. So the hard part is actually getting down to targeting specific members and groups of members and communities that need the help the most. These benefits should be designed to be manageable and sustainable, especially in their financing. The last thing you want to do with, say, a meal benefit program or a food delivery program is to run out of money in the 4th or 5th year of that program and leave a bunch of poor folks hanging on their food supply. So sustainable financing is critical. Once you get into these sorts of benefits, you don't want to go back on them. And they should evolve with experience and the data that supports their effectiveness. Go ahead, Jake. So as we look at what we're seeing in supplemental benefits for 2020, you know, I got to say the overwhelming impression that I got was one of disappointment. The plans have been predictably pretty shy about jumping into any of these new, more innovative benefits. They're largely just doing a lot more of what they were doing in 2017 before the CMS policy changed. You're seeing the greatest offering in eye exams, hearing, and in fitness benefits, you know, which are generally really inexpensive and cater more to worried well types of beneficiaries that plans think will help balance out their risk selection. Go ahead, Jake. You see very little uptake in terms of some of the interventions that we know are really meaningful, like in-home support services. I mean, dental is way up there in these last couple of years, and that's great because that is a gaping hole in the Medicare benefit design and one that has direct connection to social determinants and poverty. But you saw a big surge in over-the-counter drug benefits in this last couple of years, and more plans using OTC as a carrot for chronically ill beneficiaries to be more compliant with their medications and other treatment regimens. Go ahead, Jake. But in terms of the most creative, really very little uptake that you see out there. You know, not much in the way of bathroom safety devices, which would be critically important to prevent falls. But I'll tell you, one of the things that really jumped out at me this year was the number of plans that began offering a pest control benefit as part of, generally as part of a larger home improvement benefit. And I think that really kind of speaks to the population that we're trying to serve and how meaningful that can be. Say you got an asthmatic beneficiary. I mean, the last thing you want is that member living in a cockroach infested or moldy apartment that would exacerbate their condition when fixing it, like, you know, having a pest control guy come through there and spray the place and do some mold remediation is far cheaper than the number of hospitalizations those patients will pile up. Go ahead, Jake. So I think what we can expect to see is some broader uptake in next year. I think you're going to see a big effort to reduce and eliminate copayments and deductibles, because I think we're coming to the realization that copayments and deductibles are not skin in the game, that this isn't skin, it's real money. And when you're talking low-income people, these are economic barriers to access. And what sense does it make to put insulin on tier 2 of a formulary and charge $25 for it every time they have to go and pick it up, or to charge $25 for a primary care visit when we know seniors, especially low-income seniors, need to see their doctor a lot. So I think if you're struggling with how to first start with social determinants, start by getting rid of copayments and deductibles as the economic barriers to access that they are. I think over time we're going to see a big movement toward tiered supplemental benefits, kind of like you see in the Obamacare marketplaces with, you know, bronze, silver, gold type benefits. You know, Anthem put out a really cool aspect of its benefit design last year was, you know, the availability of home health assistance. And you could get about 2.5 hours of home health aid support every week. But say you need 2,000 hours of home health support annually. I think over the next couple of years, you'll be able to get those types of tiered benefits from MA plans as they seek to offer this kind of stuff on a broader basis. And I think we all have to assume that at this point, vision, dental, hearing, and over-the-counter drug benefits are the new table stakes. And that's really what you got to have to really compete in these very mature markets that we're seeing in Medicare Advantage. Go ahead, Jake. In Medicaid, it's a pretty similar story. You've got the vast majority of states addressing social determinants through their Medicaid programs. You've now got the vast majority of states requiring plans to screen enrollees, and then not just screen them, but then provide referrals and close the loop to actual services, and helping move community-based organizations away from just grants and philanthropy and toward billing on a value basis for their services going forward. It's really helping mature our community-based partners into the businesses that we need them to be and to be able to serve these members at scale. Go ahead, Jake. You see a number of states that are doing some creative things and really trying to work in some incentives here and some real features to their social determinants benefits as a more holistic nature of Medicaid requires. Go ahead, Jake. So what this means for all of us really is that we're going to be doing business with a whole host of new vendors and service providers that many of us have spent our careers running from like scalded dogs, generally because insurance companies thought they were magnets for adverse selection. So now all of a sudden, folks that have been traditional providers of care to the underserved, like FQHCs, community health centers, community mental health centers, are now some of your best friends out there. And you're going to be contracting, as Pam spent most of her career doing at WellCare and other places, in assembling networks of community-based organizations and providers in these underserved communities to offer these types of benefits. It's a whole new normal in network management, and we've got to figure out not just how to do business with these people, but how to help move them more toward a value-based payment environment, when in many cases, you know, some of these folks are going to be like a half a dozen church ladies in a basement preparing meals for delivery the next day. You got to turn those folks and help them into a real value-based contracting vendor that you can rely on to deliver at scale as we really get going here. Go ahead, Jake. So, as we mentioned, barriers to the broader adoption of these types of benefits are CMS didn't provide any new money for either of these new benefit designs in Medicare or in Medicaid, so we've got a lack of sustainable capital. You've got actuaries' discomfort with non-clinical benefits. You've got, if the plan has to pay for these things out of its own treasury, then it's going to have an impact to premium and will impact their competitiveness. And there's always the concern that if you offer a rich social determinant benefit design, that you're going to just be a magnet for adverse selection. Go ahead, Jake. And so in our search for some creative sources of external capital that can de-risk the offering of some of these benefits for the plans, I spent a couple of years looking at social impact bonds. There's about 50 billion of them out there, but in 40 or 45 meetings with bond financiers, I couldn't find a one of these guys that understood what the hell I was talking about in social determinants of health. So I turned to opportunity zones, and that is a much, much bigger well of money. As I mentioned at the top, we're talking over $6 trillion in available capital. Go ahead, Jake. And as I mentioned, the investor gets the maximum tax shelter benefit by leaving their money in these investments for at least a 10-year period. And go ahead, Jake. When you do that, leave it in for at least 10 years or even longer, all of those funds and all of the proceeds from those investments are completely tax-free. So this is really sustainable capital. And here you see the almost 9,000 opportunity zones that were designated nationwide. I'm actually sitting here doing this webinar from Puerto Rico, and the entire island of Puerto Rico is one giant opportunity zone, as it should be, because, boy, these folks need help down here. Go ahead, Jake. So, generally, the way that we like to approach financing these types of interventions and projects is first to start with analytics and with cohort identification of the patients that we want to intervene with first, and that we can expect will have the greatest impact in healthcare savings and improved quality for. So first, the use of sophisticated analytics to identify those members who need us the most. You then have a qualified opportunity zone fund like us invest the capital into a joint venture with our client. So our business model is we partner with a risk taker like a Medicare Advantage plan, a Medicaid plan, an ACO, a capitated provider group. And we would then set up a joint venture in one of the local opportunity zones with our client. And then all of the money flows through that joint venture is allowable for all the types of benefits that we're talking about here. Originally, opportunity zones were conceived as a real estate investment program. And really thanks to some revisions in the regs last April and again in December, you can now use opportunity zone capital as long as it flows through an opportunity zone business. You can use it for real estate, you can use it for leases, you can use it for working capital, you can use it to meet business requirements. The only thing you can't use opportunity zone money for is to help finance debt. So it suits our purposes perfectly on that basis. You then execute on that intervention, you measure it, you improve it, you then use the savings to repay the investors and then reinvest in the program. The beauty of social determinants interventions is that these are investable events. Almost every one of the interventions that we've spoken about today yields at least a 3 to 8x ROI. That's a great investment. And my God, if you hit a home run like Geisinger did with a 35x, you're going to make a whole lot of people really happy and then have a whole lot of cash savings on hand to expand that program pretty dramatically. And then you just repeat the cycle over and continuously reinvest and improve in what you're doing. Go ahead, Jake. Now, this is where I'm going to let the incomparable Pam Taylor jump in and have her grace us with some wisdom here on what the data shows us about identifying those members. Go ahead, Pam.
Thanks, John. Hi, everyone. Thanks for your time today. As John mentioned multiple times during his portion of the presentation, identifying the barriers and identifying the cohorts is absolutely essential to everything that we're doing. It starts the process, it lays the groundwork for our execution, it provides the foundation for evaluation and scaling. So what you see here is a sample profile, and we look at both the individual social risk factors, and then we aggregate that into barriers that are most prevalent in a population. And we can look at that population any number of different ways, and we partner with the health plans to be able to identify those groups. So by ingesting their census information and their claims data, we then evaluate that against publicly available data and create a social profile by individual. Jay, can you advance one? Thank you. Then we identify the most prevalent issues across populations that we want to target. Now, the reason we look at both the individual and then the population level is the individual data is then fed back into the electronic health records, and it is then used by case managers and community health workers to develop life plans, which is integral for sustaining programs and looking at the interventions. It's also woven into the actuarial models for risk stratification. So one of the things that John talked about earlier is how do we get folks who look at risk and look at actuarial tables to understand the impact of what we're doing. And this is one method. Then we also look at the population level, and we really hone in on what are the health factors and the social factors and how do they intersect. So we take a look at the number of different factors and number of different sources externally. We create the profile individually, we aggregate that, and then Jake, move forward. We then separate that out by topic. So you'll see at the core of each population, the individual risk score, which is then aggregated to look at what the most common factors are by population. Then we attach that to, say, diabetes, COPD or CHF, congestive heart failure, and we span our social interventions across those populations from an evaluation perspective, but everything ties to clinical outcomes. So for most of you who have gone through medical school, you know you have to have the end game in mind as you look at the interventions and the evaluation, and that's exactly what we do. We do this across multiple different sources of data points and populations. We really get down to who are we trying to reach, how do we engage them, how do we evaluate impact, how do we calculate savings using a methodology that everyone is comfortable with, and how do we ensure that we can scale these interventions appropriately across multiple populations. That feeds us right back into what is our value proposition as a provider and a support to the health plans. And I'll turn it back to John for the next slide.
Thanks, Pam. And just a great way to approach the patient cohorts here. So for us, you know, as we get into our first rounds of investments with some plans and provider partners, you know, the value proposition we're looking to offer is obviously to the investors. It's a long-term tax shelter. You know, because of that tax shelter, this ends up being pretty cheap capital because the margin expectations, the return expectations of these investors tend to be lower because they're also getting the tax shelter. And because, you know, you tend to see investors in two big groups here. You've got the guys who are really after some quantifiable social impact. And then you've got the folks that are really in this for the margin and the tax shelter and really from just a business perspective and tax savings. To the plans, this is about de-risking these types of social benefits, getting them to accelerate their adoption and offer them more broadly, and to move to value with a network of community-based organizations and vendors to carry out the mission. And to the beneficiaries, obviously, it's faster access to new benefits and services that improve their quality of life and their cost of care. Go ahead, Jake. So, you know, to just give you an example of some of the projects that we've got in the pipeline to help you guys ideate how to think about these types of investments. true to the research that shows a 3 to 8x ROI on most of these types of interventions, you'll see from our pipeline and from our finance shop what the return expectations are on many of these types of projects. And, they're pretty staggering from an investment standpoint. Say on project B in homelessness, that you put in, say, $11 million, and by year 4, you're making double that on an annual basis. You get to see how, in effect, while opportunity zones offer sustainable financing, it really is bridge financing, because with most of these interventions throwing off a 3 to 8x ROI, many of these programs are going to be self-sufficient within 4 to 5 years. And they will have covered the initial investment put and are now throwing off enough savings to allow not just a repayment of the investors, but a reinvestment in the program so that you can continue to service a bigger and bigger population. Go ahead, Jake. And that brings us to some questions and answers. And Jake, I think, has probably been getting a few of them over the chat utility. And we'll ask Jake if you'd like to start throwing some of those our way.
That sounds perfect. Pam and John, thank you so much for joining us today and for sharing this information. We have been getting many questions coming in. What I'm actually going to do is I'm going to jump to the next slide, which has your contact information. So that way, as people kind of hear this Q&A, if they want to be able to get in touch with you, we'll have this slide open and ready to go. So I'm going to go ahead and pause our webinar on this screen so that way I can play around with the controls and look at some of my questions. So please forgive me as I try to power read these really quick to figure out which ones to ask you. So global question that has come in a couple times is just access to the slides and the resources. So again, the recording of this presentation, the slides will be posted on PQA's member resource page in about 1 week. This first question I think is rather kind of interesting. So I'm just going to read it out loud, and Pam and John, I'll let you guys kind of decide who takes it. But I think, John, this might actually be for you. So the Treasury Department's internal watchdog announced yesterday an investigation in the Opportunity Zone program after news reports indicated that friends of the administration were benefiting from the program. Are you concerned about the program being undermined by actions like that?
Yes, I mean, of course. It doesn't help that you've got folks like former New Jersey Governor Chris Christie opens an Opportunity Zone fund so he can open up a goddamn laundromat in Asbury Park with Bruce Springsteen. That is not what the intent of this program was. And so we have seen some malfeasance and some abuse of the program already, especially in the real estate sector going forward. And there has been a bit of controversy in the way that some of the governors and mayors designated their actual opportunity zones when that had to occur last year. But nonetheless, look, anytime you've got a tax shelter program like this, you're going to see abuse of it because there is a whole cottage industry that's popped up in our country to figure out how to help billionaires hide their money. This is going to be no exception, and folks like us are just going to have to continually work against, this kind of abuse and malfeasance in the program. It's going to occur. We just hope that, some of the lights that we're starting to kindle here are going to shine brighter than the controversy.
Perfect. Thanks, John. And I do just want to put a reminder out there that we're going to try to stop Q&A at about 5 minutes till to help PQA kind of transition to the next webinar at the top of the hour, just as a time keep for everybody. So Pam, I think this one's closer to your neck of the woods. On the data analytics side, do you see that the analysis and associated interventions fitting into the SSBCI framework? And Pam, if you need more context on SSBCI, please let me know and we can ask the questioner to add that for us.
Thank you. I think SSBCI means the supplemental benefit structure. And we do align with SSBCI, but we have more flexibility. So the health plans are pretty constrained by the supplemental benefit design under MA. As John mentioned, it's really more of a cost containment strategy. So what we're looking at in terms of evaluation is more your traditional public health approach, and the design of the interventions then connects to what the health plans look at in terms of population level analytics and your blending with your traditional public health statistics. So your question is really about the funding mechanism as well as the analytics and the evaluation underneath it. The funding is a different strategy because we have more flexibility under OZ than you do under what CMS was able to do under the supplemental benefits. And the health plans have more because they're not constrained to the benefit, to the capital that they have. John, is that fair? Do we need to separate the two issues?
Yeah, that's great, Pam. Another way is also to say that a lot of the interventions that we're talking about, guys, don't necessarily have to be included in a bid. A lot of these types of benefits can be done as administrative benefits that are just provided outside the context of the bid on an as-needed basis. So, you know, you just can't put it in the bid and market them, but you can have administrative programs like some of the ones we've mentioned available to beneficiaries as needed.
Right.
Perfect. Thank you so much.
Jake.
So a couple of the questions, I'm going to kind of group them together, and they touch upon like how can we best engage community pharmacists in this type of opportunity. And specifically, one individual talked about their pharmacy and how they're employing community health workers to support patients in need and get them connected to local services specific to their SDOH needs. So how do you see community health workers kind of integrating and working with community pharmacies within this Opportunity Zone program? And if you had community health workers in your pharmacy, what would you do to increase care coordination with plans and potential partners?
Oh man, is that a great question, and just love the spirit in which it was offered. Well, as we mentioned earlier, I mean, community health workers are going to be a centerpiece of any really successful social determinant intervention. I mean, none of this stuff is worth anything unless you can find the member and engage them. And the best way to do that is with a peer, a neighbor, a friend, somebody from down the street who knows the neighborhood, knows their way around, and is a friendly face who is really there to serve as a social worker, as a caseworker for a panel of really vulnerable members. So the idea of pairing a community health worker with a community pharmacist is just awesome, because one of the most prevalent things that you see among the most vulnerable populations we want to intervene with is polypharmacy issues. And, you know, so true to Maslow's hierarchy, right? You know, unless you've got your basic human needs met, you're never going to be a compliant patient. I mean, if you're wondering where your next bed or your next meal is going to come from, the last thing you're thinking about is, did I take my insulin right today? And so a community health worker is really going to help these really vulnerable beneficiaries with their social needs, get them enrolled in all those benefit programs that they may be eligible for, getting them into stable and supportive housing if that's what's needed, getting them the meals and the food security that they need to be compliant and to deal with their polypharmacy issues. Only then is MTM going to be effective. And so to have community health workers as the tip of the spear of any complex care and polypharmacy initiative is absolutely the way to go. Now, one thing I would suggest if you want to try to scale a program like that would be to work with us on what a joint venture would look like with one of your major payers that you're affiliated with, or even more than one, and to create, say, a program like this of community health workers and pharmacists working hand in hand in these vulnerable communities, and to scale that program and make it more broadly available is a perfect use of OZ money and a great investment, and one that could be done across multiple payer accounts if that's how you'd like to approach it. Pam, anything you'd add to that?
The only thing I would add, because you did beautifully as always, is One of our biggest challenges, and the health plans face this too, is engaging consumers and making sure that they're aware of these programs. And as John said, the community health workers are a great path for doing so, but the community pharmacists have a very unique point of view and can bring a lot of that engagement to the better of the consumer. So as John said, let's engage, let's pull you in as part of the design process at very early on. I think there's a tremendous opportunity for collaboration there.
Absolutely. Jake, I think we've hit the witching hour.
I think we actually have hit the witching hour. John, Pam, thank you so much for this presentation. It was very invigorating. We do have some additional questions that came in. John will work with you and Pam offline to see how we can kind of triage those and share them back with the group.
Happy to.
So again, thank you so much for joining us. Good luck in Puerto Rico. I'm really thankful that you're able to join us down there and all the work that you're doing there. And again, as a reminder to everybody, our next PQA Quality Forum is going to be in February, on Thursday, February 20th, and it's going to be about interoperability and quality. However, we do also have a new technical education webinar, and this is where PQA is going to be sharing how we've redesigned our value sets, and that's going to be on Thursday, January 30th. So again, thank you everyone for joining us, and I hope to see many of you in 2 minutes during our all-member endorsement call. Pam, John, thank you again. I hope you guys have a great day.
Thank you all so much. It was a great pleasure, Jake. Thanks for having us. Bye-bye.